Yeah. Good morning, everyone, and welcome to yet another webinar by the Center of Excellence in Migration and Global Studies. We really appreciate all the stakeholders. We thank our Baba in the house, Professor Emeritus Sogolo, is here with us. We appreciate you, sir. He's also the editor-in-chief of the Center's International Journal. Today we have a presenter that is a big stakeholder, and then Dr. Ohame, the host, and I put hostess also to be gender sensitive so that they don't take me to the high court down the road. Dr. Felicia Ohame is one of us, is a Foundation Associate Fellow of the Center, a lecturer in the English department, but more importantly, she is also the production editor of the Center's International Journal. I would like to thank her for taking up this responsibility to host. When I step aside, she will do all the needful. We started this idea last week, the last presentation, and Dr. John Okparadoro did fantastically well. We do not expect anything short from Dr. Felicia Ohame. Dr. Felicia, you have the virtual floor. Thank you.
Can I just stay?
Yes,
yeah,
sir. Yes, sir.
I just want to apologize for being absent for some time because I've been in a way on a visitation assignment.
Yes, sir.
We just finished last week.
Yes, sir.
So
we thank God for bringing you back.
Thank you.
Yes, sir. We miss you, and I know you try to join a couple of times.
Yeah, from there,
also
but it wasn't possible.
Yeah, you sent your apologies, and we appreciate you, sir.
Thank you.
You are modeling good service and leadership, and we sincerely appreciate you. Let me also state that, thank you, sir. Professor Abdallah Adamu sent his words, I think at BUK or ABU, one of the two, I can't remember now, that there's a MacArthur event going on in his department. I think he's on sabbatical or something like that there. And he sent his apology, but said you can sneak in and sneak out because the topic is so germane and so important that he just would like to contribute as usual. Professor Femi Peters, the Vice Chancellor, will be joining us. I don't know whether he has done that already. If he has, please, we will acknowledge. But again, we thank him for giving us the support to continue to flower. And today we have a scientist, just like our Vice Chancellor, Professor Femi Peters. Dr. Felicia Ohame, you have the space now, please.
Thank you so much, and good morning to everybody. It's a pleasure to be hosting this. And it's nice to see us all. Professor Emeritus, I greet you, sir. Good morning to the father in the house, to all the professors. Thank you all for joining us. This is what we do practically every week. The Center of Excellence in Global and Migration Studies, CEMGS, commenced operation in March 2020, and since then we have been on. The center was founded by the immediate past Vice Chancellor of National Open University of Nigeria, Professor Abdallah Uba Adamu, and it has been a platform where discussions on migrations, both internal and external, have been, we have been looking into different aspects of migration. And particularly during the COVID-19 pandemic lockdown, we had the privilege of discussing crucial issues, very, very important to us and to the world from the point of human mobility. And today we are honored to be listening to yet another presenter. I consider her a specialist in the medical and public health fields. She's going to take us further on the discourse of COVID-19 and its relevance to migration. And she's no other person but an associate professor of CEMGS, Dr. Chinwe Lucia Ochu. Dr. Chinwe is the Director, Prevention Programs and Knowledge Management, Nigeria Center for Disease Control. She's also the National Coordinator, COVID-19 Research Consortium. Today, she's going to be speaking to us on a topic that I believe is very important to us all, because it borders on human existence, and that is the issue of COVID-19. The topic is the syndemicity of COVID-19, implications for global studies on the pandemic. I believe she is going to deliver, and we're going to learn a lot from her. Dr. Chinwe, you will have the floor for 40 to 45 minutes, ma, and then we will go into discussion. For whoever has a comment or question, you will use the emoji, the raised hand emoji, so that we are not disturbing the discussions. You just use the emoji, or you send me a chat. You use the chat box to indicate that you would like to ask a question or you want to make a comment. That is after Dr. Chinwe has delivered on the topic. So it is my pleasure to welcome Dr. Chinwe to take the floor from now for the next 40 to 45 minutes. Thank you. Dr. Chinwe, thank you, ma. Yes, you can go on.
Thank you very much, Felicia, for that for those kind words. A very good morning to everyone on the call. Let me sincerely appreciate, especially the Vice Chancellor of the National Open University of Nigeria, Professor Femi Peters, for this great honor. I consider it a great honor and privilege to be called to serve in this capacity of an associate professor of the Center of Excellence, Migration and Global Studies. And I also want to appreciate Professor Hakim Tijani, the director of the center, and of course, the Professor Emeritus, Professor Godwin Sogodo. It's my pleasure to meet with you today, sir, and everyone that took out time from your very busy schedules to be part of this meeting. I welcome you all. So like was said during the introduction by Felicia, is actually going to be, I've been wondering what will I be discussing for 45 minutes, but I think it's for all of us to think together. I am going to sensitize us to think more about what we know about COVID-19 and the way it has been framed globally. Everybody has been talking about COVID-19 pandemic, COVID-19 pandemic. Is COVID-19 just a pandemic? So I'm going to take us through this presentation just to stimulate us to think more about it. Probably towards the end of the meeting, we'll have time to interact and others will make comments and their own contributions. So I'm looking at syndemicity of COVID-19 and what this could be, what this could mean for global studies on the pandemic. What is a syndemic? This was a concept that a medical anthropologist came up with in the 90s, Meryl Singer, and I want to start by presenting the definition she gave of what a syndemic is. She said it is a set of closely intertwined and mutual health problems that significantly affect the overall health status of a population within the context of a perpetual configuration of noxious conditions. Okay, so if you don't mind, if you're not speaking, I'll request that you kindly mute yourself. Thank you very much. Okay, so these are big, this looks like a big drama, talking about not just social conditions and so on. But what is it all about? It's looking at a pathogen that does not exist in isolation, but what that pathogen is able to do to an individual or to a community or to a given population is dependent on how that pathogen interacts with other pathogens in the host system and how it interacts with some other diseases that could be in that same host, and even how the overriding social environment and political environment can predispose to different health outcomes in a given population. So bringing about what we call clustering, because you have different factors, biological, environmental factors working synergistically to create distinctions to make some group more vulnerable to a particular disease than others. So this is what she defined as a syndemic. And it usually involves complex interactions between not just communicable disease, but also communicable and non-communicable diseases, which could include trauma, maternal and perinatal disorders, and every other thing that we can think about, as well as ecological factors, the environment that enables that pathogen to thrive and that creates structured vulnerabilities in a given population. Socioeconomic and political factors also have a role to play. So it is a complex relationship, but there are three core things that must be in existence for you to consider a particular situation or an epidemic a syndemic. Number one, there has to be that biological interaction of that particular disease with another disease. And also the kind of social interaction that exists, social, psychological, biological interaction that exists between diseases. And thirdly, the macro social factors that enable such vulnerabilities to happen, that kind of clustering to happen in that population. So we are going to look at COVID-19. We're going to interrogate COVID-19 to know whether it's actually a syndemic. A lot of literature, a lot of articles have been written on this, and people are still proposing that COVID-19 could be a syndemic. So let us look at COVID-19, examine this phenomenon that happened last year, and we are still currently dealing with it, to know whether it is just a pandemic, which is superficial, or are there more things to COVID-19 that I can see? So we'll be discussing these questions. Number one, is COVID-19 a syndemic? So we will pass COVID-19 through the test and know whether it passes the test of a syndemic. Secondly, what does this, if COVID-19 is a syndemic, what does it mean to global research agenda on the disease, COVID-19? And does the current global research agenda, which we have, address COVID-19 syndemicity if actually COVID-19 is a syndemic? How can the gaps in current COVID-19 research agenda be addressed, or current research, ongoing research projects all over the world of COVID-19? If there are gaps in this, how can it be addressed so that it will effectively answer the questions around COVID-19? So let us put COVID-19 to test. Is COVID-19 a syndemic? Are there bio-bio interactions? Like I said before, for you to consider a disease, a syndemic, there has to be some biological interactions with other pathogens, so to say. Is COVID-19, does COVID-19 have bio-bio interactions? Now let's look at COVID-19. What is the relationship between COVID-19? What is the relationship between COVID-19 and bacterial infections? We have seen in this current pandemic the fact that people who have the infection of COVID-19 have lowered immunity and are more vulnerable to bacterial infections, pneumococcuses, and other infectious diseases that can trigger even pneumonia. bacterial superinfection in COVID-19. So we've had a lot of instances like that, and that can affect the outcome of COVID-19 in a given patient or even in a community. How about parasites? Now, there are very interesting interactions that have been observed by scholars between COVID-19 and parasites such as malaria and other NTDs. Malaria is actually a very interesting one to examine. Malaria is caused, the one that we have, and is caused by Plasmodium falciparum. And malaria infection involves red blood cells having the parasites and then getting lyse and releasing merozoites into the system that can cause pro-inflammatory reactions. We also know that COVID-19 on its own triggers a lot of inflammatory reactions through the cytokine pathway. Malaria infestation of cells can lead to that kind of a similar reaction, and it is these pro-inflammatory processes that give rise to the symptoms that are associated with uncomplicated malaria, such as fever and so on. Now, where there is a co-infection of malaria with COVID-19, then there is risk of exacerbation of these symptoms. So that could be probably the reason why those who have COVID-19 and malaria tend to have more severe symptoms than those without malaria. Malaria is also known to, trigger, to have a immunomodulatory effect, to reduce the immune system, suppress the immune system, and that on its own can also reduce the manifestation of symptoms, especially respiratory symptoms, when you have malaria co-infecting an individual with other infectious diseases. That is also what has been noticed with COVID-19, that even it is also possible that some people with COVID-19 and with malaria may not manifest severe respiratory symptoms, so to say. They might have a fever, but they might not manifest severe respiratory symptoms. Meanwhile, because of the immunosuppression, malaria parasite, and that virus, COVID-19, can spread to more parts of the body. So while it is suppressing the symptoms, it is exacerbating the viral load. And such people might not recover quickly when they have COVID-19. So these are very interesting biological interactions that can be happening between malaria and other NTDs and COVID-19. A similar interaction has also been described for HIV, hepatitis, flu, and so on. And then what about antimicrobial resistance? This is not an infection, but it is something that can worsen the outcomes of an infection. We saw a lot of people taking a lot of antibiotics without prescription during the COVID-19 outbreak due to panic. Even some doctors were prescribing without justification. And this may likely lead to antimicrobial resistance that we may have to be dealing with in the future when we now need these antibiotics. So these are some of the interactions that could worsen the outcome of COVID-19 in a given population. So let's interrogate COVID. Does it have any interaction with non-communicable diseases? What is labeled, or what people label as comorbidities or multimorbidities? It is interesting to know that what we are dealing with may go beyond comorbidities, which is a bit superficial, but there can be an interaction that will worsen the outcome of either the non-communicable disease or the communicable disease itself, which is COVID-19. Let's look at diabetes and chronic kidney disease. We know that those with diabetes have been shown to have worse disease outcomes when they're infected with COVID-19. Why? We know the immune problem, the immune problem that we have with diabetes. Those with diabetes usually have immunosuppression, and they are not able to put up that kind of resistance or to be able to generate enough antibodies to deal with COVID-19 when they are exposed. Hypertension has also been seen as a comorbidity, so to say, that worsens the outcome of COVID-19 in those that have these cardiovascular diseases. Cancers have also been associated with more severe outcomes. Those with cancer have been shown to be more likely to die from COVID-19 than those without cancer. Also has a lot of things to do with the immune system. Antimicrobial resistance, we've talked about that. What about asthma and chronic obstructive pulmonary disease? These people are already, they already have a pulmonary compromise. So when this is also superimposed with COVID-19, the outcomes are usually more severe. Sickle cell disease leads to the lysing of cells that have a pathological problem. So when such people are exposed to COVID-19, all those problems that are associated with sickling, lysing of blood cells, sickle cell, and even the potential for crisis is increased in those with sickle cell disease. Musculoskeletal diseases, COVID-19 has been known to trigger more arthritis and other musculoskeletal, to trigger musculoskeletal symptoms. That is why you see a lot of people complaining of body pain when they're infected with COVID-19. So a lot of interaction happens to lead to the exacerbation of these symptoms. And those with trauma also, they are already dealing with trauma, the immune system is already compromised, and they are more likely to have more severe outcomes from COVID-19. So let's look at, let's take some of these non-communicable diseases and look at them more closely. For chronic kidney disease, this is one big health problem that the whole world has to deal with. Of 500 million patients living with chronic kidney disease globally, 80% of them are found in low to middle income countries. The global burden of disease reported a 148% increase in mortality from CKD in 2020 compared to what they got in the 90s. And the disease has moved from the 27th to the 18th position. So we see a disease that is increasing in severity and is affecting more people over time. This is not helped by the fact that there is scarcity of organ donors for end-stage kidney diseases. This increases the risk of death for those that come down with end-stage chronic kidney disease. Patients with CKD are more likely to die from COVID-19 than those that don't have, because there are also other complications that can further exacerbate an existing chronic kidney disease, like acute renal failure. Even those with diabetes are more likely to have CKD than those without. And when these ones are also exposed to COVID-19, that kind of multiplies the risk of death from COVID-19 for such persons. How about diabetes mellitus? Globally, we have 9.3%, which is approximately 463 million persons, adults between 20 to 79 years that live with diabetes. COVID-19 patients, like we said before, who have diabetes are more likely to have acute respiratory distress syndrome, septic shock, which could also lead to kidney failure, and multiple organ damage and death. These are the people that you're more likely to admit in intensive care units. So diabetes mellitus has been seen as a great risk factor for death in persons with COVID-19, and even for more severe outcomes for those that eventually survive. Let's also look at the complications that can come from COVID-19 and see whether that can also impact on the life of those who are infected with the virus. Cerebrovascular accidents have been noticed as a common event in those with COVID-19, especially those that have underlying pathologies. And also, even the pathway of thromboembolism and that the COVID-19 virus is known to trigger increases the chances of not just cerebrovascular accidents, but also cardiac failure in patients. This is a virus that can lead to acute respiratory distress syndrome and respiratory failure, further worsened by those that already have underlying respiratory problems, like those with asthma or those with chronic obstructive pulmonary disease. Acute renal failure has also been associated with severe forms of COVID-19, as well as liver failure, thromboembolism, and so. And then, of course, lifestyle-related complications. How about obesity? Obesity is one big problem that we may not be able to assess very well until some years later. We have seen a change in lifestyle where people now sit more, take their lectures online like we're doing currently, and people are not as ambulatory as they used to be. So more people are adding a few more weight, and this is predisposing to more cardiovascular problems. Many people, we may have to be dealing with a pandemic of obesity in the near future if care is not taken. This is also the issue with hypertension. Let's look at whether COVID-19 has some biosocial interactions. Is there any way where social factors influence the outcome of this virus, either in an individual or in a given population? COVID-19 and social inequities. A lot of articles have been written and a lot of concern has been raised on the possible gender inequality in the way COVID-19 affects people and even the way the interventions are given. We know that, yes, over time we have seen that more males are more likely to get infected than females, but there are a lot of social consequences that tend to influence females in a disproportionate manner. I like to bring, let me comment on what another professor said, Professor Oka Obondi. He drew our attention to the fact that when we said there was a lockdown, that many women, especially in the rural areas, are the ones that usually go out to fetch water for their families. And these women are now forced to sit at home. And even when you tell them, wash your hands, make sure your children wash their hands regularly, they consider first and foremost the problems, the kind of difficulties they need to be able to go outside to fetch water and bring to their family. So this has brought about, a form of imbalance in the way COVID-19 and its interventions affect the various genders. The issue of gender-based violence has also been on the rise and has been reported severally in various literature. How about fragile communities? These are communities where there are either wars or cases of insurgencies, where people are less likely to access care than others in other communities. COVID-19 has also taken its toll in such communities. In Nigeria, for instance, there are areas in the north where even risk communication activities were not able to go there without exposing yourself to security risk. So these are all some of the things that affect how COVID-19 affects a particular community. Socioeconomic inequities. This is a big problem, very big problem. At the initial phase of the outbreak, people thought that COVID-19 was a big man disease because most of the people that were affected then were people that were coming in from other countries. But very soon we started having community transmissions with people at the lower economic cadre being the ones more affected, less likely to access care, less likely to afford care in hospitals. But thankfully, testing for COVID-19 was made free for all, so that was not an issue. But the true impact of COVID-19 in our economy may not be seen now. And we may need to keep an eye on the overall impact of COVID-19 in Nigerians' economy and the economies of the whole world. Everybody felt it this time around, both civilized and uncivilized world, both rich and poor countries. COVID-19 took its toll on the economy of most of these nations. Access to basic healthcare, there was a lot of disruption of routine clinical and maternal child health services during the COVID-19 pandemic, especially at the heat of the pandemic when people were afraid to even go to visit hospitals because they felt they would get infected with COVID-19. So most of these routine services were paused because of COVID-19. And that could mean that more children would have missed their vaccination doses, and there could be more likely, it could be more, we could have future outbreaks of those vaccine preventable diseases. How about persons living with disabilities? I was able to attend a meeting where these people gathered and they expressed their concerns that most of the public health interventions around COVID-19 did not consider them and the peculiarities that they have. The fact that they might not be able to access care as easily as those without disabilities. What about the risk communication activities? The deaf may not be able to hear some of those jingles that were playing on radio and television. But thankfully, the Presidential Steering Committee, which was then PTF, was able to bring in those with sign languages that were able to translate the communication to those that are deaf using the sign language. But there is still a lot that these people face that we may not understand, those of us without disabilities. COVID-19 has affected those with disabilities disproportionately. Elderly and vulnerable population. How about healthcare workers and caregivers? They are more likely to be infected with COVID-19 because they have come into closer interaction with those that have been diagnosed with COVID. Social class distinctions, I think I've spoken about this before. The fact that there are people that are more likely to access adequate care if they are infected with COVID because of their class position and their socioeconomic status. Is there any form of biopolitical interaction with COVID? I'm sure those of us in Nigeria will say yes. And even those in the US and other civilized world that had a lot of political, they utilize COVID-19 for their political purposes. What about the power differentials? We see that most of the times, even the interventions on COVID-19 adopt this top-down approach, where policies, guidelines are developed without due consideration of those who are labeled as the end users or the target population. So how this has affected the way people understand COVID-19, the way they understand the interventions, the kind of trust they have in those that are supposed to be producing these guidelines. Politicization of COVID-19 is a big problem, not just in Nigeria, but in other parts of the world. Game of powers where people use COVID for their own selfish political gain. It has led to public outrage with people not expressing lack of confidence in governments of various nations. And this has brought about a lot of divisiveness. So COVID-19 for sure has a political angle to it. How about bioenvironmental interactions? Waste generation has been a problem with COVID-19, with more people using disposable waste face masks and not disposing them properly. We do not have incinerators in many of our hospitals that can deal with these hospital waste. And even the public waste, sanitary conditions have not, the sanitary conditions have been very poor in many places with environmental pollution and contamination. And then of course, climatic conditions have also been shown to have big problem with COVID-19. Is there any way COVID-19 can interact with life and livelihood? Let's look at our lockdowns. Most countries had to impose lockdowns in order to control the spread of the virus. But this did not come without its own complications. A lot of people that depended on daily, they needed to go out. They had low to middle income, especially in low to middle income countries. People were affected adversely by these lockdowns and they were not able to fend for themselves. How about social distancing? Did this lead to social exclusion? People were not able to gather the way they used to before the outbreak. There was also digital connections and integration with more people connecting digitally, more globalization, ability to connect with people in different geographical regions. And then of course, highly skilled economy. Those in the ICT business will experience economic boom, while others experience economic collapse. There is a problem with globalization, with people, adopting Western lifestyle, and that predisposing them to the risk of obesity, which is also a known risk factor for severe outcomes with COVID-19. Global economic meltdown, and then of course, nationalism that came with the issue of vaccination. Many countries deciding to prioritize their own people and even keep the excess they have at the risk of the people in low to middle income countries not accessing vaccines. Domestic violence has been on the increase, and of course, pregnancy. With lockdown, more couples that were not together before had the opportunity of being together for a long period of time. And is it possible that we're going to have population explosion as a result of multiple pregnancies from these lockdowns? So what does this mean for global research agenda on COVID-19? You will agree with me that having interrogated COVID-19 this way, that we can rightly say that COVID-19 is a syndemic. So if COVID-19 is a syndemic, what does it mean for global research agenda on COVID-19? Most of the studies we have are solitary studies, and these will undermine the syndemic nature of the disease and prolong the deleterious societal effects even after the pandemic. It's possible that most of the research projects we are carried out now are just looking at the superficial, all these solitary studies on the virus, on the health system, on different studies, standalone studies happening at the same time, may not address the true questions that surround COVID-19. The syndemic impacts of COVID-19 could actually pose a greater public health burden than the pandemic itself. What we require is an integrated multidisciplinary research approach that will provide a better understanding of the COVID-19 syndemic and generate holistic data, which will be more relevant to policymakers in all sectors, as well as health practitioners. If we continue to ignore social determinants and consequences of this pandemic, it will further broaden the existing social gaps that we have that can lead to more health disparities, not just in low to middle income countries, but also in civilized world. We can also see that even the way COVID-19 affected civilized nations has been a big surprise to many people at this time. Is it possible that there is a syndemic relationship that people are not yet looking at that led to more severe outcomes, more people being affected and more severe outcomes in the civilized world than we are recording in Africa? Could that be a question that researchers will want to address to understand this pandemic better? Does the current global research agenda address COVID-19 syndemicity? We have a WHO roadmap that currently guides research projects on COVID-19, and it is quite comprehensive. But unfortunately, it may not effectively address the complexity of biological, social, political, environmental, and even behavioral interactions as a unit, addressing them together. The WHO research roadmap has different themes with people working on those different themes. But the ability to integrate these thematic areas as one unit and look at them with the same lens, trying to, for one area to address the other, so that we come up with a holistic answer to each research question. This is something that is still lacking in that research roadmap. Poor interdisciplinary inclusiveness in implementation of these agendas mean that complex syndemic interactions may not be adequately scrutinized by current studies. Having this skewed focus could present less in-depth, though useful solutions that quickly end the pandemic, like vaccine, being able to come up with vaccine, it will quickly end the pandemic, more people get vaccinated, they are no longer exposed to the virus. But what about those wider and broader social problems that this could have, and the gaps that this could have created? This could be long-term effects of COVID that our current short-term interventions may not be able to address. It may not address the bioecological and socioeconomic vulnerabilities that could predispose towards pandemics in the future. So the global health community may remain on the defensive rather than on the attack line. What it means is, rather than preventing future pandemics and future epidemics that could be as a result of existing vulnerabilities that we have described with this pandemic, we will be waiting for those ones to happen before we start looking for vaccine and addressing them. Little investment in integrated biomedical ethnographic studies on COVID-19 keeps the roots that feeds pandemics underneath the earth of scientific obscurity. So scientists may not be able to unravel the actual cause of these vulnerabilities, what exposes us to these pandemics, what causes clusters of vulnerabilities among specific populations, if we do not include ethnographic studies in line with, together with our biomedical studies. How can the gaps in current COVID-19 research be addressed? Let me present some quotes that will help us to know what we need to do as a global community to address these problems. Christian Adams has argued that the actual arrival of COVID-19 magnifies pre-existing vulnerability, but that the exact nature of these vulnerabilities are too often dissociated from the current drama of COVID-19 response. Also, in classifying the vulnerable, we must consider what Clare Herrick calls the politics of vulnerability. I've mentioned that before. My fear, though, is that even as the viral threat ebbs and our daily lives slowly re-emerge, the underlying health, economic, and social drivers of this pandemic will remain just as they ever were. These are very important quotes. Harish B has said, for all the suffering brought on by the COVID-19 pandemic, a broader examination of 2020 news headlines reminds us that it is not an event that is occurring in a vacuum, but rather within a complex interplay of crisis in global public health. Some of these crises are acute events with immediately devastating consequences, such as the Australian wildfires, while others, such as the epidemic of misinformation, are more insidious and slowly erode at a population's ability to promote and protect health. Clare Herrick says, if the COVID-19 pandemic lays bare our collective vulnerabilities to emerging infectious disease, the differential genesis of these vulnerabilities must be foregrounded and not merely footnoted in news and data reporting. COVID-19 has made pre-existing conditions somehow innocuous. As the days of lockdown wear on, the gripping story of this pandemic has become when someone dies without a pre-existing condition. So the exception that serves to scare us all. But NCDs now affect the majority of the world's population, and political prioritization and financial resources remain woefully inadequate. The fact that COVID-19 reveals this in such stark but under-acknowledged ways must not be the postscript of this pandemic. So we should stop labeling people as pre-existing condition or not pre-existing condition without seeking to understand why this predisposes them to more severe outcomes. Richard Horton said, without identifying and without intervening on the cofactors making SARS-CoV-2 a lethal virus, no measure will be truly effective, not even vaccines. Elena Nikiphorou said, the emerging evidence on both biological and non-biological factors implicated in worse outcomes in people with rheumatic and muscular diseases affected by the COVID-19 pandemic, whether infected by the virus or not, calls for the need to use more novel and holistic frameworks for studying the disease. In this context, the use of a syndemic framework becomes particularly relevant. So what are our recommendations? Integrated, multidisciplinary, and multi-sectoral approach to COVID-19 research. We need to include end users and target population. We need to include their perspectives in the development and implementation of research agenda on COVID-19. And global research roadmap should amplify this integrated approach of biomedical and ethnographic studies. The importance of co-production of research from proposal development to actual implementation has never been more glaring. Reconsideration of non-communicable diseases as components of the pathogenetic pathway of COVID-19 outbreak, and not just labeling them as pre-existing conditions or as superficially as comorbidities, is very, very important. We must deliberately consider structured vulnerabilities as we design global and local studies. And global research policies should be underpinned by the understanding of COVID-19 as a syndemic and not just a pandemic. So as WHO convenes experts to review the current research roadmap, it is hoped that the complexity of COVID-19 that exceeds biomedical boundaries will be more extensively explored. So in conclusion, I will say emphatically that COVID-19 is more than a pandemic. It is a syndemic. And a global syndemic research framework is needed for holistic studies on the pandemic. WHO can lead in the development of this framework, and other countries will adapt to their local context. Countries can also come up with their own framework that addresses their own context, and this will address issues. So thank you everyone for your time. I will now open the floor.
And she just finished.
Thank you so much, Ma. This has been a very interesting discussion and a fresh perspective to the issue of COVID-19 and its challenges. Dr. Ochu has done a lot of work in establishing the fact that COVID-19 is a syndemic and not a pandemic. In fact, it's a fresh perspective for me, particularly as you talked about underlying challenges, that are pre-existing in societies or that were pre-existing before COVID-19 outbreak, and the ways in which those have exacerbated the situation. And I particularly noted your point on developed nations. In fact, we were surprised to find that developed nations had a lot of deaths, the US particularly, the UK. A lot of persons died and are still dying. And that tells you that there's a link between other, health and social factors and the pandemic. But interestingly, before now, I have been looking at the pandemic just as a world public health challenge. But she's tried to zero it down to the fact that there are other factors, that have influenced the way COVID-19 has affected the world and is still affecting the world. We're going to be taking discussions on this. Thank God we have about 15 minutes to do it. If we have questions, if we have comments, we are going to be discussing.
Thank you, our host. Thank you very much. I think we have at least 4 people to go now. We thank Dr. Ochu, Associate Professorial Fellow, for that brilliant presentation. A lot of opportunities for future research is part of what I'm getting from this presentation. And I put here, maybe she will address it, or maybe someone else will also mention this. What comes to mind readily is the case of Kogi, whether or not there will be a syndemic or the start of pandemic, given the political climate and the politics of Corona Day here. It is so scary in that part of, and when you meet with people that are from the state with all sense of responsibility. I was opportune, I was invited actually, and Dr. Rekia Maman can testify to this, to a women event in Abuja about two months ago, 2.5 months. It's a football match at the national. And I went there as usual, at least 30 minutes before hour. And I noticed that a lot of the people putting up the shares and what have you, getting the whole place ready, we're not using face masks. And I asked the person, I said, well, why are these people not using face masks? And then she said, well, they are from Kogi. So at that point, she introduced me to some of the top officials and said, oh, the governor is the chairman of the occasion. I said, which governor? He said, Kogi. I said, I don't think I will stay here. And the people approached me and said, Prof, Corona Day now, we don't use face mask. I mean, they just dismiss it. This is a big challenge to us as a nation, because whether you like it or not, we always infer the phrase, let us meet at so that we can have an olive branch. Whatever it is, we meet at Lokoja, we settle case. But can we settle anything now when Lokoja is not safe in terms of either a syndemic or pandemic? Having said that, I have in this order for few minutes, not even minutes, seconds, to go and comment and either ask questions. The immediate past dean of Faculty of Science, Professor Munyolua Olani, she's here with us. We thank you, ma'am. We have Dr. Williams of Development Studies Department, and then Dr. Mrs. Alero from Law, in that order, and then the Professor Emeritus, our Baba, we crown it all, as we say in Yoruba land, Egunla Ningbe.
Okay.
That is a big masquerade we always, and I'm speaking real Lagos Yoruba, not in Gige Yoruba to you. Thank you very much. In that order, can we quickly, and then the presenter, Dr. Uchu, will now respond, and then we call it a day. Thank you very much, everyone. Thank you. Please also unmute if you are called to speak. And then for those not speaking, kindly mute yourself. It is ethical to mute yourself so that you don't get yourself embarrassed. Thank you.
Thank you very much, Professor Tijani, and the host. It's my pleasure to congratulate Dr. Oju for making this submission this morning. My observation and comment is germane to a scientist. Thank you for this presentation. However, my comment is a critical one, and I just hope you will take it in the spirit of academic discourse. In such a discourse as this, I would have expected empirical proof for us to have a conviction of what you are trying to pass across. I missed something, I can't tell, but I cannot recall seeing any set of data correlating the claims, this syndemicity, with other factors. In science, we will demand for empirical proof. And then, I also know that there are a few reports that we could even get online because people were very active during that pandemic on the impact of COVID-19 on socioeconomic situations in Nigeria, not only even in Nigeria, in several other countries, because this looked like the most common and the easiest set of information that people could get. We still didn't get any data to support this claim. So in all, for me, as a scientist, I really will not say I had a proof of the syndemicity of this disease from your presentation. Thank you.
Thank you. Next person, please. So he's talking about statistical specifics, which I think I looked at it.
Yeah, thank you very much, Prof. That was a wonderful presentation, taking us around the entire impact of the need for collaborated in relation to COVID-19. However, I have my concern some of these collaboration, or how to see the possibility of having these collaborations in future, is the fact that collaborative studies over the years, is based, it is an expensive venture, and putting a team, working on different aspects, maybe social aspect, political aspect, scientific aspect, and all the rest, could also be a major challenge, particularly in developing countries like ours. However, my concern is the continuous or increasing gap between the developed societies and the developing world, which over the years has continued to expose this kind of what I say over-dependence on foreign countries or developed nations, particularly when it has to do with health issues. And COVID-19, to a very large extent, has also, proven that. So my question is, how possible, or what do you think, developing nations can do to encourage homegrown solutions? Because I think that should be the way forward. Because if we continue to depend on the Western ideologies and all the rest, what do we do? There was this herbal tea here and there, by African nations that say, look, there's herbal tea. Madagascar was one of it. Was it really effective? So what can we do to encourage the homegrown solutions? And I think one of the issues that we may need is social vaccination on my own part. So thank you very much.
Thank you very much. The next person, Dr. Alero.
Yes, Prof. Are you hearing me, sir?
We can hear you loud and clear. We thank
Good morning,
you for finding time.
Thank you, sir. Good morning, everyone.
Yes.
Thank you, Prof. Yes, sir. I want to first of all congratulate the presenter, and also just a question. When talking about COVID-19 and social inequities, she said more males are likely to get infected than females. I was just wondering why, and if you could throw more light on that. Thank you.
Okay. Thank you very much. Before Professor Emeritus Sogolo speaks, let me add to the issue of statistical specificity. And I would like Dr. Ochu to please shed light on the activities of NCDC in the context of COVID-19. More importantly, the National Research COVID-19 Consortium, or I think it's consultant now, to buttress some of the presentation that you made earlier. We listened to Professor Emeritus Sogolo. Sir.
Thank you very much, Prof. And thank you for today's host. I want to congratulate Dr. Ochu for this very brilliant presentation. I'm not a scientist, and so my interest in this presentation is more of a concern, a personal concern, rather than the global research or global studies which she was talking about. So I'm really going to talk like a layman who's concerned with the topic in a totally different way. The reason I want to do that is I belong to one of the vulnerable groups, which the presenter mentioned at a certain age. I'm over 75, so at my age, I've gone through a lot of things. He talked about some of the vulnerable areas which we are, prone to. He talked about malaria. We've also had malaria. I'm hypertensive. I'm diabetic. Now, these are things that concern us. So when you talk when you discuss this, for you, you're talking about science. The former dean of science was talking about proof and so forth. I'm not talking about proof. I'm talking about something that is so interesting to me. I'm very much concerned. And that is the way I think many people will find this discussion. Even scientists, they are also human beings. So they're likely to find it interesting the way you have discussed it. But I have just two questions. The first one concerns what you talk about, climatic conditions. And I'm sure that countries like Nigeria, some of other African countries have been lucky in a way. And the explanation we hear as laymen is that, it is because of the climate. It is because I just want you to throw some light on that. That is one. The second one is this whole idea of variants. I've taken my second vaccine, but the threat is still there because I'm hearing that whether you have taken 2 or 3 or even 20 vaccines, the variants that are coming will still attack us. So what do we do about those variants? That's what the same variant from Delta, that I understand is the most dangerous one currently. So if you can just say something about these variants, I think it's a very brilliant presentation, and I'm glad that I listened to you. I'm not a scientist, so my concern is a physical one, like many others. Thank you very much.
Thank you very much, Professor Emeritus Sogolo. Let me ask also a personal question as a non-scientist arising from Prof's comment. If you are taking the first dose, Oxford, in Nigeria, in US, we have Pfizer, Johnson & Johnson, and Moderna. We've been told that you cannot mix it. Is there a time frame within which one should take the second dose of Oxford, of any? It is more personal question that could help others. Because I've taken Oxford before leaving Nigeria. And in the States, they told me I cannot, I should not even try it. But do I have a time limit? Say, for instance, it's going to end, I must take it before the end of June or whatever. Thank you very much. My apology if it's too personal. Some of you might be thinking, why not ask that privately? But I think it will be beneficial to all too. Okay.
Okay, I suppose I can go ahead and answer. Okay, thank you very much. And I sincerely appreciate all these comments and questions, and to know that all of us were part of the process, thinking through from the beginning to the end. So I will not assume that I know I have an in-depth answer to all the questions, but I will just express my opinions, and then others that have something to add can also go ahead and add. Firstly, thank you so much to Professor Olani for that brilliant question about presenting, using data to support, the claims that COVID-19 is a syndemic. Unfortunately, the syndemic on its own is an anthropological concept that does not deal much with empirical data. Rather, it is an observation through ethnographic studies and anthropological studies, an observation of trends and what you see that has been demonstrated to lead to a particular thing using these social science means. So there are a lot of literature, and I think that was why I presented, I showed my references, including publications in Lancet that have addressed the syndemic nature of COVID-19. There is a checklist they use in identifying which condition can be classified as a syndemic and which cannot. It's not every epidemic that could be considered a syndemic. And I think I mentioned those 3 core areas, those 3 core things that must be present before you can rightly say that a disease is a syndemic. One is you must have more than one diseases or more than one pathogens interacting biologically with themselves. For that, we all know that there are scientific evidence to show and to prove this. They are written in literature, these interactions. Number 2, is there any interaction between a disease process and another disease process, not pathogen now, but a disease process and another disease process? And then are there also interactions with the social environment, with the political milieu, with all these socioeconomic factors and all these what we call macro-social factors? Can they predispose a particular population to more severe outcomes than others? So if you can show these interactions, and it's usually done, and that's why, like I said, the conventional studies that deal with empirical evidence have missed these kind of macro social factors that we're talking about, because you may not be able to elicit them using your conventional method. And that is why the end of my lecture is calling for a more holistic approach that we utilize. Yes, we need the evidence, we need all those, but we also need the aspect of ethnography to show and explain, try to understand why some groups of persons, these clusters exist, some group of persons seem to have more severe outcomes than others, using the ecological theory to explain that. So I put COVID-19 through the test, these three core areas, and COVID-19 seemed to, pass the test on these three areas of consideration. And that was why I drew my conclusion that it is a syndemic. Actually, whether people have considered that before is not even questionable, because there are a lot of publications on it. But I felt that with this group of intellectuals, we can look at these things and examine them ourselves and draw up our own conclusion. Is it true that COVID-19 has some social consequences? Definitely, yes. Is it true that there is an interaction, there can be interaction between COVID-19 and other bacteria and the malaria parasite? I spoke about the immunomodulatory effect of malaria, and how that can suppress even the symptomatic forms of COVID-19 while increasing the viral load. It is also from literature that was pulled up. So I'm sorry if I'm not able to show data, but these kind of studies do not come up with conventional data to support them. Rather, these are deep conceptual theories coming up with conceptual frameworks that you will use to identify societal problems and seek to address them. Yeah, the second question I was talking about, yes, Professor William, you rightly noted that corroborative studies can be quite expensive. I agree very much with you. And maybe I will also bring in Professor Tijani's comment on the NCRC here. Like I said, difficult problems requires, us looking inward as a nation and identifying local ways that we can address this situation. So a good platform that provides opportunity for corroborative study is what we have in the NCRC, the Nigeria COVID-19 Research Coalition, where we have various, experts, both social scientists, virologists. We have about 10 thematic areas with experts working in them. That is fine. But I think we also need to go a step further than just having the categories, by now letting the teams now work together. If the social science working group, they're able to get a grant to support a study, why don't we adopt an integrated approach where we can as well use that opportunity to investigate maybe the virological component, all those other, or the clinical management aspect. So when you have this form of integrated approach and you develop a proposal where the social scientists are part of the team, the biomedical science, they are there, and all the other experts, they are part of that common team, and they develop a common proposal so that this will provide a more in-depth understanding of the issue at hand. And remember, if we say it is expensive now, in the future, we'll have to deal with more expensive outcomes. So the earlier we develop a framework, and I am suggesting that WHO should come up with that framework, and the nations can adapt. It can even emanate from us. We can develop, and WHO can also share with WHO, and they can also modify it to meet the global needs. So these are areas that we should go home and think about and see how we can come up with this form of framework. Then the third question, okay, sorry, Professor William also asked, what can developing nations do to encourage homegrown solutions? It's still the same thing, having that platform where we support research on indigenous products. This is the only way we can come up with good solutions, indigenous solutions to our problems. There are a lot of people claiming that their herbs can cure this, but most of these have not been subjected to rigorous scientific examination. So we want more of these, and I like what NAFDAC is doing currently pairing herbalists with scientists to help them examine their products and come up with what works for the country. So that is the only way we can begin to make use of these indigenous products. Then Professor Akujobi, as he said, why is it that males are more likely to be affected than females? There's actually a lot of proposition, a lot of, this is still an area that research is still going on concerning. Some link it to hormones, you know, the androgen and go. Others at the beginning of the outbreak, they said more males are more likely to travel than females. There are so many propositions, but we have seen that, yes, hormones, the role of testosterone and androgen in this, I mean, that predisposes men to be more at risk of getting infected is there. Then men in some settings are more likely to be the ones going out and interacting with people than women, but not in all settings. So these are all issues that need further interrogation. Then activities, okay, I've mentioned NCRC. Thank you very much, Professor Emeritus Sogolo, for your kind words. And he talked about climate, the role of climate. This is another area of controversy that a lot of studies have been done on climate and its possible effect with controversial findings. Some tell you that the higher the temperature, the less likely the virus is to thrive, but others have also debunked that. So we are still trying to understand the role that climate has to play. But you know that in some weather conditions, especially in Nigeria, during the Harmattan season, when many people were more predisposed to flu-like symptoms, we had a spike. We had more cases of COVID-19 than afterwards. So climate for sure has a role to play, but what that role is what we need to investigate further and come up with concrete findings. Remember that COVID-19 is still as novel as it can be, though we now have a lot of data to support certain evidence on COVID-19, but there is still a lot that we do not know about the virus. And then finally, talking about the time frame for taking the second dose of COVID-19 vaccine. Is set at 8 to 12 months, but it keeps shifting. I know NPIs has come up with 6 to 12 months now. So I suppose that after 12 months, it's not advised that you wait beyond 12 months to take it. But it's also been discovered that the further apart the first and second doses are, the more likely you are to generate more antibodies against the virus. But the time frame for now is between 8 to 12 months. So I don't know whether I missed any question. And please, any other person that knows this subject better than myself and has an answer to a particular question can please.
What about variants? Variants of COVID-19, variants.
Okay.
The most recent.
You want to know whether the vaccines are effective against the variants?
Yes.
No, there's a question about variants.
Sorry, I didn't get that. Sorry, sir, if you can come again.
No, I said there's a variant they call weather data variant, which I say is so dangerous. Does it really afflict those who have taken the vaccine? I don't know whether there can be an answer to that.
Okay, thank you, sir. I think current evidence that we are seeing published by CDC and others have shown that the current vaccines that we have in the market are effective to a particular extent against the current variants that we have. But the ones that have the least ability to, generate antibodies is the B1, is it a 612? Sorry, I've forgotten the one they call the India variant. That one does not, people with that variant do not generate antibodies as fast as others, but they generate enough to protect them. So there is no big concern now there's no big concern. Sorry, was it 8 to 12 months I said? Thank you very much. Somebody wrote on the chat box, it's actually 8 to 12 weeks, not months, sorry. That was a slip. It was 8 to 12 weeks and not months. That could mean you will stay a whole year before you take the next dose. No,
Yes.
8 to 12 weeks. Thank you for that. So there is no big concern now about the efficacy of the current vaccines that we have in the market against the various variants. So we are encouraged to go ahead and take these vaccines. We are still learning, and as more evidence comes, they will be churned out, and it will guide future recommendations.
Thank you. Thank you.
Thank you very much for your presentation and also comments. We deeply appreciate you. We will be glad to view your paper for publications, and we do peer review, we do publish. We don't charge you, except that NCDC can give the center some big grants free of charge. We will definitely accept it to encourage young scholars. I can see Dr. Paradu, smiling. So he's coming, don't worry. We will also appreciate, and I think it's really going to help your paper, some statistical specifics, even if it has to do with just Nigeria, within the context of this pandemic or syndemic. I believe Professor Jegede UI is having challenges. I would have loved for him to make some comment. He is the chair of our social science NCRC. I'm the co-chair. That is the National COVID-19 Research Consultant under the NCDC umbrella. But he is in and out. So I will use the virtual floor to Dr. Paraduru, who will do the vote of thanks. But before he does that, let me thank profusely Dr. Felicia Oame, who accepted to do this. Less than 24 hours. That is what leadership is about. That is what we are mentoring at this center. We appreciate all. Dr. Paraduru, you have the special floor, and then we can conclude.
Okay. Prof, thank you so very much. I'm highly delighted for this honor you have given me to give this vote of thanks among the big masquerade. First of all, I must thank so very much our Vice Chancellor, Professor Lufemi Peters, who has made it possible for us to be here, giving us the actual support for continuity of this center, the Center of Excellence in Migration and Global Studies. Kudos to our father in this noble institution. And also I must thank our distinguished Professor Emeritus Sogolo, Professor Sogolo, in fact, his daddy, one and only, who has been there to mentor us that are coming behind the young, small ones. Thank you so very much. Your support is quite immense, and you have given us everything we need. But you have not completed it, sir, because we're expecting more. Oliver Twist said, I need some more. So we need more from you, sir. And our own director of this center, no other person but Professor Tijani Hakim. You're a good mentor in this, I must say it, because last week, that's how you just gave me opportunity to just be the host, not up to 24 hours. And I tried my little ability, which you say is okay. And the same thing you have done to Dr. Felicia Omen today. That is essence of mentorship. Thank you, sir, for mentoring us. And we promise not to disappoint you nor the institution. Also, able thanks go to the presenter, to all the professors in the house, please, before I skip and be hammered on my head. All the professors from all and sundry who are in this meeting today. I say thank you all, those who make comments and those who do not make. And of course, when one has said what you wanted to say, you say, yes, I cannot say anything because someone has said what I want to say, no repetition. And then to the presenter of today's webinar, Associate Professor Chinua Ochu, for a brilliant and wonderful presentation. Thank you and God bless you. As I thank today's host once more again, Dr. Felicia Omuamen, and every one of my colleagues in this presentation today. For your time you took to be here, it's a great sacrifice. And I know very well that we have all benefited quite immensely from all questions, comments, contributions arising from today's presentation. And I say next week is another day, Wednesday, same time, 10 a.m. on the dot, we have comments. Thank you all and God bless you. Say bye-bye.
Thank you. Let's clap for
Thank you
Professor
so much.
Ochu. Thank you very much. Thank you. Thank you.
Thank you.
Dr. Oame, you can leave and close everybody.
The opportunity.